Okay, so this is part 3 of the series. This is a series of talks on the kidneys, ureter, and bladder with some overlap in IR, some overlap in nuclear medicine, and a little bit of overlap in the GYN malformations. Same as the other modules, we've got 3 basic types of questions. All right, starting out with a gamesmanship style question. This is a very important strategy here. This is the multiple MRI sequences. See, here's how I handle these. This is my suggested strategy. First thing you want to do is make sure you know which each sequence is and sort of have that in your mind. So that's the first thing that I want to do. So let's do that now as an exercise, and I'll sort of give you some tips. So this one here is a T2. It's obvious that there's CSF in the canal. But let's say that the picture was cropped so that you couldn't see the spinal canal. What are some other things you could use to tell that this was a T2? The gallbladder is helpful. The stomach is helpful. The urinary bladder is helpful. And then here's another trick that I use for kidneys. This perinephric sweat that we see a lot here. Pretty much everybody always has that. So even if they coned in right down on the kidney and you could see nothing else, you can tell that's a T2 because you can see a little bit of that sweat, as opposed to this guy over here, which is a T1, which you can't really see that sweat on. So back to this one. So we've said it was a T2, but is it just a T2? It's a T2 fat sat, and I like to use the sub-Q fat to just quickly, boom, tell that that's what that is. You could also use the intraperitoneal fat, which is also satted out. So this is a T2 fat sat here. We already mentioned that this one is a T1, so spinal canal, and then all the opposite things that I mentioned before that you can use. No sweat here. Don't see the gallbladder, urinary bladder, but those things you can use if they are messing with you and excluding the spinal canal. This is a post-contrast. You know it's a T1 post-contrast because you don't use gadolinium with T2. T1 shortening causes brightness, right? And then this is a subtraction image, and let's talk about it now on why do you do subtraction. So things can be bright on T1 post-contrast for two reasons. One is that they enhance, and then the other one is the pitfall, which is that they were intrinsically T1 bright, something like a proteinaceous cyst, which this person actually has. So this is T1. We've got a bright cyst. So is that cyst bright because it's, so if we just looked at the post-contrast, is that bright because it's enhancing, or is that bright because it's intrinsically T1 bright? It's hard to tell, right? So the computer does some math and subtracts out the pre-contrast intensity, and what you're left with is whether or not there's actual enhancement there. Stepping back just for a second, too, when you deal with these kinds of questions, it's good to have a running differential in your head of what is T2 bright, what's T1 bright, what's T2 dark, what's T1 dark, what restricts diffusion, what does not restrict diffusion. It's very helpful with regard to gamesmanship to sort of have that in your mind for problem solving. Also pay attention to, this is a really quick way to do, is this a fat-containing lesion? Look for a or non-fat saturated sequence and a fat saturated sequence to just immediately tell if that thing has fat in it. Another basic gamesmanship tip that we talked about in the liver module, which is there in and out of phase imaging? If there's in and out of phase imaging, and they've provided that for you, more than likely it's a question that revolves around the presence or absence of fat. So here's a zoom up. So this was our pre-contrast T1 image here, and this is this is our post-contrast T1 image here, and this is our subtraction. So we can't tell whether or not it's enhancing truly here. We look on the subtraction, we see that there's not any internal enhancement. Somebody make an argument that this is a little bit of rim enhancement. I think it's just stretched renal parenchyma, and I would let that go. Now, what about this guy down here? That's also T1 bright, and that appears to be enhancing. So you can see right there that there is some internal brightness. It shouldn't be there. So that's enhancing, so that's a renal cell carcinoma. Now, typically they won't treat these things if they're under 1.5 centimeters. Most interventionalists won't burn them or freeze them if they're smaller than that. That's just something to have in the back of your back pocket just in case it would come up. Also, I just want to make a brief, this is just my opinion, I would think that if they would show you a subtraction case, that it would not be an eye exam. It would be obvious that the thing was enhancing or it wasn't. I don't think they would be like, oh man, is that little speckle there? What do I do with these little speckles? That's not enhancement. Don't call that enhancement. It's going to be white in the middle if it's enhancing, if they're going to show it to you like that. Just a quick review. There's 4 basic types of renal cell carcinoma that most people talk about. And more important than knowing that there are 4 types is knowing the trivia associated with them. So clear cell is the most common. This is the one that avidly enhances. People will say it enhances equal to the cortex on corticomedullary phase. And it's the one that's associated with von Hippel-Lindau when you have bilateral renal cell carcinomas. Papillary is the second most common. There are actually 2 types. You've got a type 1 and a type 2. Type 2s tend to be more aggressive. That's probably above the scope of this exam. Just know that they do happen, and they tend to enhance less avidly, less the cortex on corticomedullary phase. And they're on the T2 dark differential, which is a classic differential we'll discuss in a minute or two. Medullary, this is the one that's associated with sickle cell trait, underline trait. It's important, that word trait. Don't miss that. Because if I was going to write the test and I was going to write some distractors, choice A would be sickle cell, choice B would be sickle cell trait, I would assume. Or maybe I would make choice D sickle cell trait, because assuming that you'd get sloppy and you wouldn't read all the choices. Remember, read all the choices on every single question. Chromophobe is an uncommon subtype. You see it in Berthog-Dubé, which also gets bilateral oncocytomas. Oval cysts in the lungs and some weird skin shit. All right, so let's talk about staging. What are some important things to know about staging? So renal cell carcinoma loves to grow into the renal vein. Probably seen lots of cases like this. How can you distinguish between bland thrombus and tumor thrombus? It can be hard sometimes. Supposedly it will enhance. And if it was shown on ultrasound, it would have flow in it. Again, I don't think there'd be an eye test. If this question came up, I think it would be obvious that it was enhancing, or it would be obvious that it had flow in it. And if it wasn't obvious, then I would say that it didn't. So which one's worse, renal vein invasion or ipsilateral adrenal involvement? So you think that vascular invasion would be bad, and it is bad, but the adrenal is actually worse, because that means that it's broken through a fascial plane to get to the adrenal. It can slide right down into that renal vein, and that's how I remember it being worse. Was there fascial involvement or not? If the fascia's been invaded, then it's in the adrenal. It can still technically be within the, it's just sliding down in the kidney into the renal vein. So it's not aggressive enough to have broken through fascial plane. So we touched on this a second ago. T2 dark lesion. So this is a classic differential. Multiple choice radiology doesn't typically do a lot of differential questions, but it's useful to have this to know what this could be. Academic radiologists tend to love this particular question for some reason. So there's 3 things: lipid poor AML, hemorrhagic cyst, and this papillary subtype renal cell carcinoma. All right, what about this one? So gamesmanship, sequences first. Okay, this is a contrasted CT. We've got the coronal plane. They've managed to show us 2 planes here. And it's an enhancing mass, and a lot of you will probably think, okay, enhancing mass, that's RCC. That's always RCC. But it's funny looking, right? It's got this sort of stellate central scar thing going on here. And that is more common in oncocytomas, allegedly. This is a really, really nasty type of question because oncocytomas look a lot like renal cell carcinomas. They're an enhancing mass in the kidney. They occur in the same age group. The only real difference is that they tend to have the stellate scar, and they'll have a spoke wheel appearance sometimes. There is an association with Birt-Hogg-Dubé, like I mentioned before. It's really, really, really a silly distinction to make because even if you would biopsy this thing, you still have to treat it as an RCC because renal cell carcinomas can have oncocytic features. Let's go back to this for a second. So how do you handle this thing on multiple choice if somebody shows you this? Man, I don't know. I think that if it has a central scar, and it looks like this case with a central scar, or it has a spoke wheel pattern, I guess I would probably call it an oncocytoma. Otherwise, it's an RCC for sure. If it's a management question, it gets handled like an RCC. So I wouldn't watch it. If you ended up with some kind of a linked question where you called it an oncocytoma and then they wanted you to do follow-up management style stuff, I would still treat it like a cancer and cut it out. And I think that's probably the most important part. These get partial nephrectomy, even though they're benign, because you can't tell the difference. All right, here we go. So, coronal plane gamesmanship. When you see the coronal plane, you think about three things: kidneys, bile ducts, spleen. Those are the three pathologies that are most easily shown on this cut. Now, if you're cut forward, they can show a bowel obstruction. It's a good way to show a bowel obstruction, I think, in coronal plane. But the cut that's further back, more retroperitoneal cut, is going to be kidneys, bile ducts, spleen. So that's the things that I look at on this cut. So there's a fat-containing mass here. I'll just tell you that it is originating from the kidney. So this is an AML. Now, is it okay for AMLs to have calcification? The answer is nope. Nope. If you see calcifications in a fat-containing mass anywhere near the kidney, it's a cancer. If it's coming out of the kidney, it's an RCC. If it's not coming out of the kidney, it's a liposarc. Any fat-containing retroperitoneal mass, by the way, that's not attached to a kidney is a liposarc until proven otherwise. Calcification just makes it that much more obvious. So what about this? Boom. 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 So AMLs can bleed, right? As they grow larger and larger, their vasculature becomes more and more disorganized, and when it gets to around 4 centimeters, they're at risk for bleeding. So angio will typically treat them around 4 centimeters. The classic association is TS. They're usually multiple. Probably have seen this, working these things up, looking at the 100 of them that they have bilaterally. Okay. All right, here we go. Ultrasound. Ultrasound renal cases. Here's for the purpose of gamesmanship, this is how I like to address single cut ultrasound kidney pictures through the kidneys. If they show me a left kidney, I think that it's probably going to be a focal lesion. If they show me a right kidney, I think it's about echogenicity questions, and here's why. Because if you show me the right kidney, you're also showing me the liver, and that gives me like that. You're like you I don't believe in coincidences. I don't think they exist in the world of multiple choice. So if you've deliberately chosen the right kidney, I feel like you've chosen it because you want me to see the difference between the right kidney and the liver. If you've shown me the left kidney, you're not worried about that. and it's more likely to be a focal lesion. So this one obviously is a focal lesion question. It's a hyperechoic lesion, and you're probably thinking, well, that's obviously an AML, because we just talked about AMLs, and AMLs are hyperechoic. True, that's true. But most small renal cell carcinomas, and when I say small, I mean less than 3 centimeters, are also hyperechoic, specifically the papillary subtype. So the important take-home point here is that if you're forced to choose a single answer, I would pick AML. If it's a next step type question, you really need to get contrast on board. You need to either do CT or MR, and for real life, that's the way to go too, because a hyperechoic lesion in the kidney is not for sure an AML. In fact, it can definitely be a cancer, so it requires further workup. Gamesmanship question again here. So axial CT with a coronal reconstruction, contrasted. We've got multiple masses through the kidney. They have provided this coronal image so that you can see that there is sort of preservation of the shape of the kidney, and you've got these masses in the upper and lower pole, and one that's sort of exophytic off the medial portion there. They're homogeneous, and they're not really enhancing that much relative to the cortex. So the cortex is a nice thing to use as an internal control, especially on a corticomedullary phase, which this is. So just as a rapid review, remember we said clear cell renal carcinoma will enhance avidly, equal to the cortex on corticomedullary phase. Papillary subtypes tend to enhance less than cortex, but they still enhance. And anytime you say the words homogeneous mass out loud, you need to follow that up with lymphoma. So this is another case, same pathology, different patient, also has homogeneous masses, bilateral kidneys. So this is renal lymphoma. Renal lymphoma can look like a lot of things. It basically comes in 2 main categories. You can have a ball type that grows exophytically, creating a contour deformity, and then you can have a bean type that uses the renal parenchyma as a scaffolding and grows. It may enlarge the kidney, but the shape is typically maintained. And this is actually the most common type, multiple masses, homogeneously enhancing. But remember, it can be solitary, so it can look like a whole bunch of different stuff. If I was going to show it on multiple choice, I would show you multiple homogeneous hypoenhancing masses bilaterally. That's how I would show renal lymphoma. So what's it look like on PET? Well, just like lymphoma anywhere else, it's avidly enhancing, super duper duper avidly enhancing. So there's really nothing else that's going to look like that in the kidney. All right, this is a good review of some cystic disease in the kidneys. So there's 2 questions you want to ask yourself when you're doing cystic renal syndrome stuff. The first one is, what's the size of the kidney? Is it big, normal, or small? And the second question is, are other organs involved? And the ones you care about are the liver and the pancreas. So let's look at this first one, the one at the top. The kidneys are big, and there is disease in the liver. So this is your adult polycystic kidney, big kidneys, cysts in the kidneys, and in the liver. The second one has normal-sized kidneys, but there's cysts in the pancreas. Remember, this is VHL. Now, there'll be other stuff in the pancreas also. Cystadenomas, maybe some islet cell tumors. You may have pheochromocytomas in the adrenals nearby. And this last one has the small kidney, so you can think about, this is an easy one to remember, right? So this guy's got, he's a vascular path, he's shrunk his kidneys, now he's on dialysis, and he's getting this cystic disease that you see in dialysis patients. Okay, so coronal view through the kidney here. And remember I said kidneys, biliary system, spleen. It's obviously a kidney pathology question. They're enlarged, right? Big kidneys, lots of cysts. So we know this is adult polycystic. We can also see the cyst in the liver, just like our cartoon case. Now, onto this guy. It's a right kidney. Remember what I said about that? So it's abnormal echogenicity, sort of bright, heterogeneous. It's real heterogeneous. You almost get the idea that he might have some microscopic or not microscopic, but a lot of small cysts, as opposed to the big ones that are more macro, more microcysts on this side. So this is the adult subtype, and this is the juvenile subtype, or autosomal recessive subtype. So what are the differences? Let's talk about the adult type first. So AD for autosomal dominant, AD for adult, that's how I remember that. And then the other one is the other one. They're typically normal at birth because it presents in adulthood, AD for adult. They have hypertension because they have kidney problems. And as we said before, the kidneys are big. They tend to have cysts both in the kidneys and in the liver. And then the what's going to kill them question is usually the berry aneurysm. So another thing that sort of looks like a cyst, but this time it's in the head. Now with regard to the kid, autosomal recessive, remember, because AD for adult, the other one is the other one. They're abnormal at birth because it's a pediatric disease. And instead of having big cysts, they have little cysts because they're little people. And here's the really good take-home point here, is that they, instead of having cysts in the liver, they have a fibrotic disease in the liver. And that fibrotic disease is inverse to the degree of the renal disease. In other words, bad kidneys, mild liver, mild kidneys, bad liver. And this fibrosis develops into cirrhosis, portal hypertension, etc., just like in an adult, and that will cause death. So really, really bad renal disease actually causes a perinatal death because of the Potter sequence. You have bad kidneys, you can't make urine, you can't make amniotic fluid, you can't breathe in the amniotic fluid, and then you get pulmonary hypoplasia. So you don't develop your lungs, so you die early on. Mild renal disease, like I said, is going to result in severe fibrotic disease in the liver, and they're going to end up having death via cirrhosis. So does polycystic kidney disease increase the risk of renal cell carcinoma? This is a great trick question. It doesn't, but it sort of does. So polycystic kidney disease does not in itself carry an increased risk of renal cell carcinoma. However, dialysis does. So you get adult polycystic kidney disease, you end up on dialysis, and then you have an increased risk of renal cell carcinoma. So yes, they do, but yes, they don't. And it all depends on how you write that question. It could be a source of significant fuckery. I would read the wording of that question very, very closely if it would happen to come up. So next question, more cystic disease. This time they're small cysts. And I will tell you that this patient has a history of mania. So I'm hinting here that this person is on lithium. And I'd be very surprised if they said the patient is on lithium. They're not going to say that because that gives the answer away. They have to hint somehow that this patient is a bipolar, has a type 1 bipolar disease. This patient has history of mania. This patient has recently been in a psych ward. This patient has history of psychiatric illness, etc., something like that. To sort of hint at the fact that this person could be on lithium. Or they could just not tell you at all, and then the question could be something like, Instead of what is it, it could be what medication do you think this patient has taken. There's lots of different ways you could write a question about lithium kidneys, but it's a bunch of small cysts and a normal-sized kidney. Remember, when you're working at cystic renal disease, the size of the kidney is helpful. Okay, so we're going to compare and contrast these things. So notice that this kidney here is in the nephrogram phase, whereas this kidney here is in the corticomedullary phase. And the more obvious thing to notice is that he's got pelviectasis and some caliectasis. So let me make an important point that hydro does not mean you're obstructed. If I gave you Lasix and then I went and ultrasounded your kidneys, you would have hydro. It doesn't mean you're obstructed. What does mean you're obstructed is if you have a delayed nephrogram like this. The kidney has a capsule to it. So back pressure is actually decreasing perfusion. That's what you're seeing. The urine trying to get out against an obstruction, either a cancer, fibrosis, a stone, is causing back pressure, and that back pressure is causing delayed blood flow, which was the reason you have this appearance. That by itself defines obstructive uropathy. Hydro does not mean you're obstructed. Over here, this is the classic way to show a persistent nephrogram, where this person has had contrast hours ago, and then you get a plain film up on the floor, and they have these super bright kidneys. So the delayed nephrogram versus the persistent nephrogram. Defines obstruction, as I said. Renal failure from hypotension, from a severe contrast allergy resulting in hypotension, shock, ATN. So let's talk quickly about some high-yield trivia regarding renal stones. This is the 6 things that I would know. Calcium oxalate's the most common. Uric acid is unseen on plain film, U for U. Uric acid unseen, and that's on plain film. Now what about CT? CT will pick up all the stones except for the indinavir stone, which is a protease inhibitor that HIV patients take. Because it's the only stone that does this, it makes for a great question. Remember, exceptions to rules make great questions. Struvate stones are classic for infection. Staghorn stones are seen with the H or XP, XGP. So anytime you see the big bear claw kidney and you're thinking that's XGP, I always look for the big staghorn, and that makes it like, boom, got that. For sure that's what that is. If you're on the fence and you can see the staghorn and it looks like a bear paw, then you can go with that. Horseshoe kidneys get more stones compared to a regular kidney. The reason is they have drainage problems, so they get more stones. They also get more infection. Because they get more infection, they also get more cancers. Renal cell, Wilms, and carcinoid is all more common in the horseshoe kidney. And yes, you can get a carcinoid tumor in your kidney. It's very, very rare, but described in horseshoe kidney specifically. All right, so back to gamesmanship with ultrasound. Remember what I said. The left kidney is more likely to be a focal lesion. You can certainly have focal lesion in the right kidney, but this is just things to think about in your head. The right kidney is more likely to be an echogenicity question because you've got the liver right next to it, and this is a perfect example of that because we can see that it's, compared to the liver, it is bright. Now, here's the second tip I'll give you with regard to gamesmanship and ultrasound. Anytime there's calipers on something, it's probably too big or too thick. How do I know it's too big? Because it has calipers on it. They put calipers on it, and it's too big. So we have a big, bright kidney. And if I told you that this person enjoys anal sex with male prostitutes while at the same time using IV drugs, that would probably give it away. This is your HIV kidney. Big, bright kidney that is failing. It's common in HIV patients. It's actually the primary cause of renal failure. They could show it on CT, but CT kidney and HIV just means it's infected, and that is a very large differential. Okay, so that's the end of part A. We will pick back up with some IR stuff, some vascular stuff, a little bit of nuclear medicine, and of other few miscellaneous things.